Hello, everyone. Good afternoon. Thank you all for joining us for our Prescription Drug Abuse, Understanding the National and Local Picture webinar. We're excited to have you all join us today. My name is Natalia Martinez-Duncan, and I will be the facilitator for today's session. Just kind of trying to give the participants a minute or so to join us, but I think we'll just go ahead and get started because we want to be respectful of your time. So before I go ahead and introduce the presenters, I did want to turn it over to my colleague, Christy Miller, so she can just give you a few instructions and tips on how to use the Blackboard Collaborate system.
Hello and welcome, everyone. My name is Christy Miller, and I am the Deputy Director for Innovation and Outreach here at CADCA. And what you should be seeing on your screens right now is a visual of the webinar system that we have, that we're going to be using today. And so to give you a quick tour of the webinar system for those of you who are new to Blackboard Collaborate as a webinar delivery system, you will see on the right-hand side the PowerPoint presentation for today. And that's the whiteboard, and you'll see each of the slides as the presenters go through them. You can, when you signed in, you should have been signaled to download the PDF version of the PowerPoint slides that are being offered. If you were not signaled to do that, but would like to do so, or if you were signaled but you clicked no because you weren't quite sure what that's for, I can tell you right now how to go ahead and access the PDF of those slides and download them. You'll go up to the toolbar in the system and you'll choose the window option. And then below window, you can choose Show File Transfer Library. And you should get a dialog box that has a list of files. And from there, you'll see one file that says CADCA RX Drug Abuse Webinar. And there should be an option where you can either download it or save as to your desktop. You can do a save as, and you'll be able to have those slides and follow along with us. We also will be sending the slides out post-webinar if you don't get a chance to do that. So moving along from the whiteboard, to the left side of the system, that top panel is the audio and video panel. So if you're having any volume challenges or if we were using video, you would be able to interact through that panel. We are not going to use any video today, but just to let you know for the future. Below that is the participant panel. So there's a box that is labeled participants. And you can see the list of individuals who are currently on the webinar. You can scroll through it yourself, and we will be scrolling through it throughout the webinar to see who's on and see any comments or smiley faces that you're offering us. For example, you may be able to see it says participants, it says your name, and then it says main room, and it has a 91 next to it. That means that 91 individuals are currently have joined the session. So welcome to all 91 of you. Right above where it says main room and it has a list of participants, you should see 4 small boxes. The first box has a picture of a grayed out picture of a face. If you hover over that box, you can see some emoticons. And you're welcome to sort of signal to us your smiley face or laughter, applause. If when someone says something that really resonates with you, you can signal your approval and disapproval, even confusion if you have some questions about anything. So perhaps if everyone would be willing to hover over that smiley face picture in the participant box and click a smiley face. I'd love to see all of your smiley faces. I see Amy's and Beatrice. Excellent. Belinda's giving us applause, so you found what I'm talking about. Next to the smiley face in that participant window is sort of a picture of a bust, and if you hover over that, it says step away from session. If you need to quickly walk away or go to the restroom, you're able to push that button, which will keep the system running, but not identify you as being in the room. Immediately next to that, the third option is a hand, is the palm of a hand, which is the option to raise your hand. So if a speaker is talking about something very urgently and you have a question that you want to ask immediately, you're welcome to raise your hand and we'll call on you, because typically that means that you need us to clarify some information right away, and we'll ask you to ask that question in the chat window. And then all the way over, the fourth option has a letter A. So again, we're still in the participant box. There are four boxes. There's a letter A. If you hover over that, you will see A, B, C, D, and E. That's our polling option. And so if we ask you questions where we want to have you respond yes or no, then you might see that A, B, C, D, E change to a green check and a red X, and it'll be labeled yes and no. You'll see the alphabet, etc. So when we ask you a polling question, instead of typing the answer in the chat window, we're asking you to go to that box and register A, B, C, or D as your response, because that way we can then publish the poll results and actually have a record of that information from you. Below the participant window is the chat box. And so you may see the chat box and you see a long list of names and saying that Betsy1 joined the main room, Debbie1 joined the main room. Excellent. So we know that there are now 106 of you all who are joining. But this is also going to be the crucial place where if you have questions, if you have comments throughout the webinar, we'd like to ask you to register those right there in that chat window. It works like a typical chat window in instant messaging or your link system. So let's everyone try it right now. For example, if I was to ask you to type your first name, your last name, and then the name of your organization and press enter, then we will see everyone's responses start to show up. What I'll do, so you see that I typed Christy Miller in CADCA. What I'll do throughout the webinar is if you're asking questions in that chat window, I'll do my best to respond to those immediately. But there might be questions that you have for the particular presenters, Maureen or Bill or Shelley, and what I'll do is I'll record those questions, and as we get to the Q&A section, then I'll make sure that those questions get directed to the individuals that they need to be directed to. So I think that gives you a brief introduction to the system. Like I said, feel free to continue to register your first name, your last name, and the name of your organization. And then also, please do register any questions you have along the way, or comments or suggestions for other information. We'd love to be able to see those. And now I'll turn it back over to Natalia.
Yes. Thank you, Christy. Okay, so I just wanted to take a second to introduce you to our presenters. So we're really lucky to have three really great presenters joining us today. First, you're going to hear from Dr. Maureen Boyle, and she is the Chief of the Science Policy Branch over at the Office of Science, Policy, and Communications at the National Institute on Drug Abuse, commonly known as NIDA. Then you'll also hear from Dr. Bill Geary here from CADCA. He's the Deputy Director of Evaluation and Research. And we're excited to also have with us the coalition leader from Kentucky, Shelley Steiner. She's with the Carter County Drug-Free Coalition in Kentucky. Then this is, as you'll see here in front of you, is an agenda. So just kind of give you an idea of what we're going to be talking about today. But without further ado, I don't want to waste too much time. I want to go ahead and let Maureen get started with her presentation.
Great. Good afternoon, everyone. I first wanted to thank CADCA for organizing this important webinar series on drug abuse and prescription drug abuse, and for inviting me to participate on behalf of NIDA. This is obviously a very high priority area for NIDA as well as for our federal partners. So Today, I'm going to talk about a number of key points to set the stage for Bill and Shelley's presentations that will follow. These points include how drug abuse patterns have shifted over time and how prescription drug abuse issues have become a major problem within the U.S. I'll talk about how behavioral factors differentiate pharmaceutical abuse from or use from abuse. And we'll discuss addiction issues and how they transcend the differences between pharmaceuticals and related illicit substances. And talk about how interventions can be effective, both primary prevention as well as targeting overdose and addiction. So we can get an idea of the scope of prescription drug abuse problems in the U.S. by looking at the Substance Abuse and Mental Health Services Administration's National Survey on Drug Use and Health data. And basically these show that prescription drug abuse is second only to marijuana in illicit drug use in people over the age of 12, with 2.6% of individuals over the age of 12 misusing prescription drugs. And this slide shows the breakdown of that 2.6% and shows that the majority of prescription drug abuse involves prescription pain relievers that you might know as OxyContin, hydrocodone, those type of prescription opiates. And then there are also misuse of tranquilizers, stimulants, and sedatives.
They have to do more with whatever they have on the internet. Not wanting us to.
To get a picture among adolescents, we looked at United's Monitoring the Future survey, which shows that about 15% of seniors in high school, so 12th graders, have misused a prescription at some time during the year. The majority of these among 12th graders is amphetamines as well as prescription pain relievers. And so just to note that these categories aren't exclusive, so Adderall would basically fit into that amphetamine category. And so that the majority of prescription drug abuse issues amongst teens tends to be these amphetamines as well as opioids.
Yeah, wrong.
And the Monitoring the Future survey also looks at prescription drug abuse by college students. And basically they found that after a period of decline, we've seen a recent increase over the last 4 years in the prevalence of stimulant abuse. And thankfully we're seeing a decline in opioids as well as tranquilizers. But the increase in stimulant abuse is somewhat concerning. And there's a thought that this is driven by the use of stimulants by college students to cram for exams and or to remain alert during their tests and during finals. And so this is an issue to be aware of. And what's also worrisome is that the increase in abuse is paralleled by a pretty dramatic increase in the prescription of stimulants. With over a tenfold increase over a 20-year period, and you can see in the red and the green lines that this is largely both Adderall and Ritalin, so methylphenidate is Ritalin, and that over the last couple of years we've seen a pretty sharp rise in Adderall. And this has been associated with an increase in emergency department visits related to stimulant medications. I see on this slide that you can't actually see the males on this, but it basically is just slightly above the female line. And basically we're seeing amongst both females and males a pretty steady rise in emergency department visits related to stimulants. And if you look at the bottom graph, you'll also see that this increase has been most profound amongst the older age cohorts. So starting with the aged 18 to 25 and older, we're seeing a very dramatic increase in emergency department visits. And we've seen a very similar trend with prescription opiates. And we've seen a near tripling of opioid prescriptions from 91 to 2013. Although in the last couple of years, really the last 2 years, we've started to see a slight decline in these prescriptions that may be the result of some both federal and state policy initiatives aimed at improving prescribing practices for prescription opiates. And this this increase in prescriptions has paralleled a sharp increase in opioid-related overdose deaths, as well as treatment admissions for opioid use disorders. However, as we noted in the last slide, prescriptions have just recently started to decrease, and concomitantly we've seen a slight decrease in overdose deaths related to prescription opioids. However, at the same time, we're starting to see an increase in heroin-related overdose deaths. And in the last year's data on this, that the reduction in prescription opioid deaths kind of was overcome by the increase in heroin overdose deaths. And the vast majority of people who are abusing prescription analgesics are directly or indirectly obtaining them from prescriptions. So more than 75% of people are either obtaining them from their own doctor or doctors, or getting them free from friends or relatives. And when we look at where their friends and relatives are getting them, the vast majority of those are getting them from their doctor. And so this suggests that improving prescribing practices has the potential to have a profound impact on this epidemic. And this graph basically shows how these overdoses compare to different drug types. So prescription opioid overdoses accounts for the vast majority of overdose deaths in the country. There's been a rise in the rates of benzodiazepine-related deaths as well. And actually, interestingly, so opioids in combination with benzodiazepines is a particularly lethal combination. And so there's been an increase in individuals with both opioids and benzodiazepines in their systems when they overdose. And you know, as you can see by this, these are profoundly higher. The prescription opioid overdoses are profoundly higher than what you see with either cocaine or heroin. We've also noted that there's been a shift in the trajectory of drug use, and particularly opioid drug use, where in the 60s and 70s, most opioid users initiated with heroin. And this started to shift, over those decades, and starting in the 90s, more people were initiating opioid abuse with prescription opioids. Although, as you can see towards the end of this graph, the trend has just started to reverse with which we believe is a product of prescription opioids becoming less available. So this figure shows the effects of abuse-deterrent OxyContin being introduced into the market. So there's been a big push to develop prescription opiates that have abuse-deterrent formulations, so basically making them more difficult to crush and either inject or snort. And what we've seen when you can see from the dotted line where abuse-deterrent OxyContin was introduced into the market, and you start to see a gradual decline in the abuse of OxyContin. Unfortunately, at the same time, what we've seen is that that's been paralleled by an increase in heroin abuse. But it's important to understand that prescription drugs are very similar pharmacologically to illicit drugs. So for example, in this particular slide, cocaine and Ritalin are structurally very similar, and they act on the same sites within the brain. This is also true of prescription opiates and heroin. There's a significant similarity across the different types of opiates, and they're biological effects are also very similar. So when used improperly, prescription drugs can be just as dangerous and just as addictive as the illicit drugs that they're similar to. So what's the difference between therapeutic use and abuse? So one of the differences is the dose and frequency of dosing. So under the care of a physician, typically you'll see lower doses with a fixed regimen. And when people are starting to develop abuse or addiction issues, they start to escalate to higher doses that continue to increase. There's also the route of administration, where higher doses, so basically a drug is more addictive and more creates a greater high when it reaches the brain faster and at higher concentrations. And that happens when people are injecting drugs, snorting them or smoking them, especially compared to oral use, and especially with these more abuse-deterrent formulations. And so as people progress to abuse and addiction, we often see a transition to these alternate routes of administration. Another difference is the expectation of the drug's effect, where psychologically there's an impact of expecting a clinical benefit versus looking for a high and the euphoria that comes along with that. And also the context of administration matters, whether you're taking this in a hospital or at school versus, whether you're at a party and you're combining this with alcohol or potentially other drugs of abuse. But we do want to reiterate that it's still possible to develop dependence when following a doctor's orders. And that's why it's critical for providers to understand and consistently evaluate risk for patients who are receiving chronic treatment with some of these abusable drugs. And NIDA, we always like to highlight that addiction is a brain disorder. And drugs of abuse affect many neural circuits, including those that control motivation, memory, executive function, inhibitory control, and reward. And abusing drugs changes these circuits in ways that make it harder and harder to stop, eventually producing addiction. So dopamine is one of the key neurotransmitters that mediates reward within the brain. And natural stimuli can produce a release of dopamine in these reward areas. So for example, when somebody is eating something they enjoy or they're being aroused, that causes dopamine levels to increase within these reward areas and lead to a positive response within the animal. And this basic mechanism of controlled dopamine release and reuptake is carefully shaped and calibrated by evolution in response to normal healthy rewards that are critical, so rewarding behaviors that are critical for our survival. But drugs of abuse also increase dopamine transition in these same areas of the brain that mediate reward. But they do so at higher levels and for a longer duration than natural rewards do, which can make natural rewards seem somewhat less attractive by comparison. And here we have some examples from amphetamines, cocaine, nicotine, and morphine. And this was shown pretty acutely by this study that was looking at the brains of cocaine users compared to individuals without an addiction. And in the cocaine users, when they're viewing a film that includes cocaine images, 3 areas of the cortex that are involved in reward and motivation light up. The cingulate, the anterior cingulate, and the inferior frontal gyrus. But interestingly, these 3 areas also light up in controls in response to an erotic film. But the activation when cocaine abusers or cocaine users view the same film was significantly diminished compared to the controls, suggesting that they're no longer responding in the same way to these natural rewards that are important for our long-term survival, and suggesting that drug abuse and addiction are changing how the brain functions in response to the normal environment. I also wanted to highlight that addiction is also characterized as a developmental disorder. So those who begin using drugs in adolescence are more likely to develop an addiction and more likely to experience harms from addiction than people who don't begin using until their brains are fully developed. So the adolescent brain is continuing to develop and is not fully mature until the early to mid-20s. So the use of drugs during this time period influences brain development and alters the trajectory in ways that increase the risk for addiction. So one key question that we get asked all the time is whether all users become addictive. So use is not the same as addiction, but heavy use and early use have consistently been associated with an increased risk of addiction, and not just for the particular drug, but for addictions more broadly. So using alcohol or nicotine, early in development is also associated with an increased risk of developing addiction for other illicit drugs. And you can see here that there's a big range of risk for addiction, with tobacco being one of the most highly addictive substances, and psychedelics and cannabis and analgesics coming in at about 5 to 10%. But I do also want to mention that specifically for cannabis, the risk for addiction seems to nearly double when individuals begin using during early adolescence. So what all this means is that addictions are relatively common developmental brain disorders that depend on neurobiology. So the social and environmental factors influence neurobiology and the risk for addiction. So things like stress in the home, exposure to drugs of abuse, trauma, and those type of factors all combine with an individual's biology to affect their risk for developing an addiction. And then exposure to alcohol and drugs alters the brain's reward pathway and these brain mechanisms, ultimately leading to addiction. So what can be done about this? I'm just going to, I know that the later speakers are going to be talking a little bit more in depth about some of the programs that are going on across the country to address these issues. I just wanted to highlight that prevention programs can be effective. And this slide highlights the Strengthening Families program, which is a universal implementation of a prevention program in schools that includes both parenting, youth, and family sessions, and focuses on increasing protective factors, basic resiliency factors such as self-esteem and direction and purpose in life, and also training for life skills, so emotional management skills and social skills and academic and job skills, to increase these protective factors and decrease the risk for addiction. And in this study, for every 100 adults in the general population that started misusing prescription drugs, only about 35 adults that received the intervention started. So this is a highly significant improvement, obviously. And so far, there have been 3 separate studies that have addressed the impact of these type of universal prescription prevention programs on prescription drug abuse and found them to be effective. So the prescription drug abuse epidemic, as I mentioned, is a high priority across the federal government and across many state governments that are seeing significant problems associated with this. And there are a number of initiatives underway to address these problems, including dissemination of primary prevention programs, development and dissemination of abuse deterrent drug formulations, overdose interventions such as distributing naloxone to healthcare workers as well as to at-risk users to help intervene in the case of an opioid overdose. And there's significant efforts to increase access to treatment, especially medication-assisted treatment, and to increase education among both clinicians as well as the public. And through one of these efforts, NIDA is working on our NIDA Med program to educate providers on the research behind this opioid epidemic, as well as on the efficacy of prescription drug monitoring programs, intranasal naloxone, abuse deterrent formulations, and other non-narcotic mechanisms for treating pain. And there's a number of efforts going on across Health and Human Services to support this larger priority. So just a quick review of the key points that we went over. That drug abuse patterns are shifting over time, and so it's very important for us to be up to date and aware of the data that are coming out. That behavioral and pharmacokinetic factors can differentiate pharmacological use from abuse, but that these addiction issues transcend whether something is a pharmaceutical versus an illicit substance, and addiction and dependence are issues for prescription drugs just as they are for illicit drugs. And that interventions can be effective, and so both primary prevention as well as targeting overdose and addiction treatment are very important to stem the tide of abuse that's been going on. And so I just wanted to point you to the drugbabuse.gov, which is NIDA's website, and to where you can find some materials on NIDA Med and our other efforts on prescription drug abuse. And so now I'm going to turn it over to Bill Geary.
Yes, hi everybody. I am Dr. Bill Geary. I am the Deputy Director of Evaluation and Research here at CADCA. First of all, thank you for all that great information. And I think part of my role today is going to be talking a little bit about how we can take information like this and apply it at the local coalition level, because I think while there is a lot of good data on trends, notice that coalitions can operate at the individual community level as opposed to, say, national or state level. And so sometimes with issues, particularly like prescription drugs, I think coalitions get a lot of exposure to national data sets, and all of that is relatively easily accessible, but they don't get a lot of data, or they face more challenges around data around their local communities. So I want to talk a little bit about how we can make this transfer from these larger data sets and these larger pools of information to something that is more applicable so that we can design specific intervention strategies that are effective at the local level. And so as we're thinking about that, the first place to stop, I guess, in thinking about what coalitions should be doing around data, which of course is my thing under evaluation and research. And typically we tell coalitions that they are going to track 4 kinds of data, right? And some of this data you saw presented at the national level. So for example, when we're talking about emergency room deaths for prescription drugs, that would fall under the first category of consequences. And we need to track consequences as a coalition, obviously, because that is what we're trying to prevent, right? We're trying to impact the negative consequences that prescription drugs are having in our community. And so while we are interested in reducing the use of prescription drugs, the primary mission is to make sure that our community is a happier, healthier place to live, right? And that it's safer particularly for youth. So we need to be tracking that consequence data because that will tell us what is the impact that our coalition is having on the actual lives of people in our community. In addition to that, and some of you have heard this before if you've been to the academy or if you've been to some of our trainings, we want to talk about the behaviors. And basically the question we're trying to address here is what are the rates of prescription abuse? How much prescription abuse is going on? When we're talking about behaviors, we're thinking more along the lines of how many, how often are these things occurring. We also want to track risk factors, and that was something that was mentioned previously, talking about risk factors at our communities. So while there may be certain risk factors that are increasing at the national level or at the state level, or sometimes if your community is even smaller than a county, at the county level, those risk factors may or may not be applicable to what's happening in our community right now. So we need to figure out what the risk factors are in our community, and this is where we start moving up to the environmental strategies, right? Because we're going to look for those things that are going on in our community that impact everyone so that we can design strategies that will impact everyone, and we refer to that as universal prevention. So we want to know what are the risk factors, and for those of you who have heard this before, I apologize for revisiting it, but of course we can't just make up risk factors, right? We're looking for risk factors that have been demonstrated in the science as being relevant to the behavior we're trying to address. Because if they are not relevant to the behavior we're trying to address, then we may not be as effective as we could be. So we want to make sure that we're basically hedging our bets, and we want to make sure that we're addressing risk factors that will give us the most impact for the resources we're going to use. The way that we access those risk factors then is we ask coalitions to collect information on what we call local conditions. The local conditions are what are the specific patterns of abuse, and you saw a little bit of that in the presentation earlier when they were talking about things like, is it injected or is it smoked, right? Whereas the problem behavior stuff, which is just involves the rates, how many people are using it, the local condition data is really fleshing out how is it being used in our communities. So we like to refer to this as the how it's being used, where it's being used, are there patterns of use going on? Is it before school, after school? Is it at parties? If it is at parties, where are these parties occurring? These are all the points of access and the patterns of use that we ask coalitions to consider. And again, we're looking for information that can be used to develop a comprehensive set of strategies that address the problem at the environmental level or at the community level. So thinking about these different types of data, and you've seen examples of these at the national level, the challenge for coalitions then is to think about what kind of information can we use at our local level to help us get to where we want to go. So we can take advantage of some of these national data sets, right? And I've seen coalitions who are able to do this. So there's a couple ways that national, or what we would call maybe macro level data, right? Data that is beyond our community might be helpful to us. And the first is the data types. So if you're having a conversation around prescription drug abuse and you're thinking, for example, what are the kinds of consequence data that we could be looking for in our community, the national data might be very helpful. That national data is collected for a reason, right? And that reason is because the national data around consequences has been determined by NIDA or other folks to be relevant to the problem. So thinking about, for example, if they're collecting data on the national level around emergency room deaths, is that something that we should be collecting in our local community? Does that kind of data help tell us something about abuse in our communities? So we're going to think about, I guess, using those national data sets and the kinds of questions they ask, and then ask ourselves, are the answers to those questions relevant to our local community, right? So again, I'm not going to collect data at the local level just because it's being collected at the national level, right? I'm going to use that national level data as a guidepost for us to have a conversation with our coalition and with our community and ask, here's some of the data that's being collected at the national level. Does any of this data make sense for us to collect? right? So we're going to look at data types. We're also going to look at data sources. Some of the things I know that some coalitions have come across, for example, at state-level data, is that state-level data is often aggregated local data. That is, you have local jurisdictions who are turning in data to some agency at the state level, and then that agency just aggregates or pulls all that data together and spits out some kind of state database. It is possible, depending on how the system is set up, that the data that's being presented at the state level can be disaggregated. That is to say that if we ask them what is the data for this county, say if we're doing a county, they would be able to tell us that. But we don't know that unless we ask, and I will be honest and tell you that typically if that can be done, that's where the coalition really has to offer a lot of support to that agency, because probably the agency's data system is not built to spit that information out very easily, right? And so some types of data are only collected at the state level, but other types of data are just, as I said, aggregations of local data. So maybe you have hospitals who are reporting out. Maybe you have police departments that are reporting out within your jurisdiction. That data may be handed over to you even before it gets into that big system. So thinking about how is the data collected, and I would urge folks, if you're interested in that kind of question, the first place I would start is just call those agencies at the state level and say, how do you collect this data? Where does it come from? And they'll be able to tell you if there are local agencies or groups in your community that are giving them local data that you may not know that they're handing over. And that's usually a pretty easy way to then reach out to those agencies and say, hey, is it okay if you provide that for us, or is there something we can do so that you can get that information out to us? So again, with data sources, can that data be localized? The last is collection templates. So once we figure out what kind of data we want to collect, once we figure out where that data could come from, and if it's not archival data, which means we don't have some agency that can disaggregate it for us, we're going to start asking ourselves, well, how do we get that information? And again, using the state or the federal template for collection of data. How do they get the data, right? And so we can copy that. I think the clearest example for this with coalitions that I've seen, I've been doing this for about 16 years now, and the one I think is the easiest is when there's some type of state survey, right? And they ask youth in schools at the state level about 30-day use, or about lifetime use, or about where do you get whatever drug it is that they're asking about. Sometimes that information is not disaggregated, so a local school district can't find out how its school district did on the state survey. So what coalitions will sometimes do, under, of course, the careful supervision of someone who kind of understands data collection, which is usually their evaluator, they will recreate questions and distribute them themselves. So they may not do another school survey, but what they might do is they may start having focus groups or listening sessions, and they'll use the same kinds of questions that are used in the state survey so that they can start collecting data at the local level. So again, it's thinking about what are the templates that are in place, what are the data management systems that are in place, and can we build a smaller, localized data management system if one does not exist for us already. So one of the things that I wanted to be able to do, and I know that there's a lot of people on the call, and this is the first polling question I think that we're using, but I want folks to be able to get a sense of what kinds of information other people are using who are on the call. So for those of you who are collecting data on prescription drug abuse, it's indicating, are you using youth surveys? Are you using treatment data, emergency room responders data, law enforcement data? Are you using listening sessions, focus groups, or some combination of those? If you could fill out the poll to let us know, just click on which of those are applicable to you, And then if you're using another kind, if you could put that in the chat window. And the reason that I want to do that is this call is being recorded, so we can go back and look at what are the kinds of data sources that folks are using. So I'll go ahead and give you a little bit of time to do that. And feeding right off of that then, we're going to talk a little bit about the coalition perspective as we move forward. So I see a bunch of folks putting in, and if you're putting in things, I'm sorry, if you're putting in things like, oh, I see what you're putting, okay, Pennsylvania Youth Survey. Youth Survey is our main source. All of the above are going by. Hi, Nan. I'm glad you could make the call. Nan and I had a conversation earlier. Poison Center, okay. T collection, I don't know what that means. Youth Surveys, law enforcement data. Youth Survey, law enforcement. So it looks like a lot of folks are using youth surveys, and it looks like other folks are using treatment. Listening sessions are good. Thank you, everybody.
I'm going to go ahead and publish the polling results for you, so you can also get a good idea of perhaps the primary source that some participants reported, which looks to be A, Youth Survey.
Yeah, and that's the primary one. And I also see, it looks like a lot of folks, well, I guess haven't filled it in. I guess that's what none means, right? People haven't hit anything. So one of the things that then based on this, and good, there's some conversation going on the type of law enforcement data that's being collected, and that can vary. That's always, as Christy, thank you for that, knows, I also am a former employee of a police department, so I'm always interested in police data. If anybody has any questions about that, please feel free to contact me, and I can help with that, because that's what we used to do. But youth survey data, thinking about what's the kind of data source that matches up to our need, right? So while youth survey data is very, very helpful in identifying risk factors typically, or even sometimes identifying the problem, youth surveys are typically not specific enough because they're kind of these broad brushstroke approaches. They're not specific enough to really allow us to flesh out the local conditions. So part of thinking about what kind of data source we want to use is also thinking about what kind of data source matches the kind of data we need. So if we need local condition data, then probably listening session and focus groups are going to be right at the top, certainly of my list, right? Youth surveys, as I said, appropriate for the other kinds. Emergency room responders data, it really depends on what does that data look like. If it's just numbers, that is to say, if it's just telling us basic patterns of use in terms of who's using and how often they're using, then they would fall in the first two categories of problem or risk factor data. But if we're having responders, for example, tell us where people are typically using, and if they're using in groups or they're using by themselves, are they using with other substances, that kind of data lends itself more towards local condition data. Right? And I think in the screen is my email, wgeary@cadca.org. If anybody has any questions about that, there was a quick question from Eileen about what we mean by listening sessions, town hall meetings. Yeah, listening sessions can be the same as town hall meetings, and I just want to cover this quickly so everybody is aware of what this means. Focus groups are different than listening sessions. Listening sessions are basically we gather a bunch of folks together. We have some guiding questions. Usually they're not very big groups, but our primary job is just to allow the conversation to unfold. That's a little bit different than a focus group, which typically has a lot of very structured questions, and you control the conversation more. So listening sessions are very informal, and again, if there are questions about what that means or what any of this means, even if emergency room data, what kind of data do you get, treatment data, what kind of data do you get, you can email me, or you can contact our technical assistance hotline, and we'll be able to help you there. Okay. So having gone through all that, I want to hand this over now to get a coalition perspective. in terms of this issue, because I know that that's what you folks want to hear. So I thank you all for being on the call. I'll be listening in for the rest of the session, and I'm going to hand it over. Thanks.
Thanks, Bill. This is Shelley Steiner, and I am the Drug-Free Communities Coordinator with the Carter County Drug-Free Coalition in Carter County, Kentucky. And one of the things that we talked about was how we got started, because it's kind of interesting. We had some local school officials come over to the Regional Prevention Center and talk to us about working on why test scores were so low. And so when they were doing their data analysis for the school test scores, what they came up with was that test scores were low because of substance abuse. They had low attendance, they had truancy, kids who were coming to school that had had no sleep, you know, and all kinds of different local conditions like that. So we started working with them. One of the first meetings that we had about 70 people there, and it was a bunch of local citizens who were concerned about the problem and wanted to see what they could do about it. So what we did was split people up and looked at what data we had and what data we needed to get a hold of. So we had our Kentucky Incentives Project student survey, which we do in 6th, 8th, 10th, and 12th grades, and we do it every other year. So we had data from that for about 3 years worth of data. And we took that, looked at it, and saw what a big percentage of 10th and 12th graders we had that were using prescription drugs. And we started looking at other data that went along with it. Some of the other questions that were in there was on school safety, where kids felt safe, where they didn't feel safe. And so they used that in conjunction with the use data, and were able to start working on strategies at the schools. But we had a lot of law enforcement there too, which was great. We had Kentucky State Police who were working with DEA and Florida law enforcement, because we had a lot of people who were traveling to Florida to pain clinics and bringing back massive amounts of prescription drugs, opioids, benzodiazepines, and so we were seeing a lot of overdoses from that. So when we sat down and started really digging into the other data that we had, we saw, you know, that we really needed to see what the community norms was. So we did a community norms survey, and we wanted to do one that was defensible, that we could, you know, defend the data. So we had somebody from Arkansas to come in and do this survey. And then we did a community readiness survey also. And just to see where folks in the community were at, you know, what they perceived the problem, whether they perceived there was a problem even. And so we took all of that data and sat down and really started looking at strategies and activities that we could do to really work on the problems that we had locally. As you can see on here, our 10th grade KIP survey, the past year use prescription drugs, in 2004 it was 17%, and the last one that we did in 2012 was 1%. We just did one this fall, but we haven't received the results back yet. So that's a 94% decrease. And the thing about the student survey is that it really shows that it wasn't just one thing, and that's what we've talked about a lot lately. It wasn't just one thing. It's been a comprehensive approach. And it's been a comprehensive approach from all the different sectors. Our faith community had a big part in getting an awareness out. You know, we had church bulletin inserts. We had a group who did an awareness march. We've had churches who have done trainings with some of their small groups, and even on Sunday night services. We've had in the schools, they put in curriculum in 3rd through 9th grades. So we've had evidence-based curriculum in the schools since about 2005, 2006. And we're really starting to see some difference, you know, in what we're doing, and that it's making a difference. We've also, here as soon as I go through these, I'll kind of go through some of these things that we've done. One of the first things that we did was an awareness campaign, a social norms campaign. And what we did was we used the data that we have to drive what our messages were going to be. And I think that was a vital part of showing people what kind of problems we had locally. We did many trainings at coalition meetings. Our Red Ribbon Week, we did Plant the Promise, Paint the Town Red, high school student presentations at elementary schools. Here are some of our media campaigns that we did. We did one on doctor shopping is illegal, and then what the punishment is for it, because we had a lot of people who were going to multiple doctors and getting a lot of the same prescriptions. Forget everything your mother taught you about sharing, because in our area, it's very common for families to share prescriptions. You know, you may not have the money to give prescriptions, and your grandmother has some in the medicine cabinet, you know. So we tried to show people that they really needed to think about these things. Locking up prescriptions. We started trying to get the information out about people who come into your house to work, you know, if things are out on their kitchen table or on an island in a basket, you know, that they need to be conscious about putting those things up so that people won't get into them. We did newspaper ads. We did sports program ads, push cards, and the push cards, we were able to get those in bank statements when pharmacies would staple them with prescriptions. We had them out at grocery stores. The billboards were down by the post office. We were very deliberate in where we put the billboards. We were very deliberate we had 47 businesses who either had up signs or gave out information to their customers. And so we had a lady come in, and she said, you know, she said, I went to the post office. She said, I saw a billboard. She said, then I went to the bank, and they gave me more information. I went to get my prescriptions, and I had a push card stapled to my prescriptions. She said, and then I went home, and my daughter told me that they were going to do Teens as Teachers training so that they could go out to elementary schools and teach younger kids about the effects of prescription drugs. So it was like a saturation of these messages, and we did that for the probably first 2 years really heavily, and that really brought an awareness, and we were able to get people who were really interested in getting involved, because in the first 2 years we didn't have before the media campaign, we didn't have a whole lot of money. We started out with just people who had the passion. And then once we were able to start the SPIF process, Strategic Prevention Framework process, people understood that we were able to do things in a way that would really start affecting our rates. And then we were able to get SPIF-SIG money, and then we were able to apply for a DFC grant and was able to get that. So now we're in our 7th year and have really showed our community that with everything that we've done, that we're starting to show that we've made a difference. We had a high school student back when I first started that said, you know, the adults in our community think that there's no hope. And he said, but really, he said, it's going to take us showing the adults that we can make a difference. And he really was a driving force with our youth. And our youth has been a big part of our coalition, and showing the adults that they don't want things to be like they were. And so now we've got such a big group of people who are really working to make our community a better place. And we're starting, this year was the 2nd year that we did Community Change Agent Awards. And that was just to really recognize the people that are trying to make a difference in our communities. We talked to our key leaders. We talked to national, state, and local legislators about what was going on and got them on board. And some of them are part of our coalition. We did, like I said, we've got life skills training in grades 3 through 9, Generation RX in the high schools. We do teams of teachers, Safe Homes Network, parent and adult trainings. We did a parent mailer, drug court support, funding for drug investigation, overtime and training, funding for drunk and drug driving checkpoints. We had a pain clinic ordinance, which was one of the first in the state of Kentucky. School administrator and teacher in service training. We gave the teachers a checklist. We had a teacher luncheon and talked to them about the danger zones begin at home. We worked with the schools on school drug testing policy for staff and students. We did a healthcare professionals training on pharmacology, polypharmacy, and addiction. Prescription take-back, permanent drop box at the sheriff's office. And then we've got some other things that we're still working on, drug-free workplace initiatives, healthcare providers initiatives, family and youth events, and then other environmental strategies. And like I said, you know, we really stress to our community that it takes everybody to combat this problem. And we were blessed to have a community that was ready and that was willing and able to get up there and do the work. So if you have any questions, I guess I'll turn it back over to Natalia.
Yes. Thank you so much, Shelley. That was wonderful and a lot of information. Just a reminder that we'll be emailing everyone the recording of the webinar as well as a PDF of all the slides, because I know Shelley went through them pretty quickly. And I know we're short on time, and I appreciate you all for sticking around. I did want, some questions came up throughout the session. I just wanted to address a few of them. And I know a few of you are still typing in your questions there. We'll try to get to them if we can. Let me see here. Let me start with one.
Yep. So it looks like this question was directed during Maureen's portion of the presentation. And Maureen, Michael was talking about or asking about, does the lifetime diagnosis of ADHD play a role in the availability of stimulant medication, i.e. if someone is diagnosed at a young age but either grows out of the diagnosis or doesn't feel a need for the medicine for his or her condition, so they give or sell them to their peers. Any comments, any speculation on sort of his thoughts there?
Well, I haven't seen data on that specifically, but I think that's exactly the type of thing that we think is, when people are, for opioids as well as stimulants, when they have extra medications laying around, there is a market for them if they choose to sell them, or as Shelley was just saying, people can go and take them out of your out of your medicine cabinet when you have a party. So I do think that type of thing is an issue where where extra drugs end up laying around and available.
Thank you, Maureen. And if I may stay with you for just a moment, on your slide 28, which let's see, I'll go to really quickly for all of the viewers to be able to see which slide we're talking about. So let's see, it was around the yes. So do all users become addicted? So the questions were, can you summarize the research that shows the human brain is still developing into the early to mid-20s? And then sort of as a piggyback, there was a question about, has this information on this slide changed? Because Becky noticed that the citation was from 1994, which is now about 20 years old.
Yes, so that is has been a concern for us as well, because we've, especially around the marijuana issues, there have been a lot of questions about its addictive properties. And unfortunately, this is the most recent data that we have on this. And it's something that NIDA is looking to address in the coming years, and to see if we can kind of get more updated data, especially in the context of potentially higher levels of THC within marijuana. And then the data that shows that the brain is developing is actually, it's a hard one to draw a line to say that your brain is officially mature at a specific point. But if you go to, I think it was this, well actually I think I might be able to do that, yes, okay. So this slide basically shows the areas where the cortex is continuing to prune and formalize its connections. And so the young brain typically has significantly more connections and synapses that through experience tend to be narrowed down to the final circuitry of the brain. Although final is a difficult word because your brain throughout your life has a certain level of what we call plasticity, a certain level of ability to adapt to the environment and change. But that is much higher in adolescence, and so you can see in the brain images that the highlighted areas of the brain are the areas that are still undergoing significant restructuring across time.
Excellent. Thank you. Thank you, Maureen. Hopefully that helped at least many of the users be able to, participants in today's session, be able to get a better understanding. And I see Glenn Johnson, who was the person who had asked that question, say thank you. So it looks like you did get to that very much. So thank you, Maureen. Let's see. Moving on to Bill. These couple of questions are for you, and they're really around how to be able to engage certain sectors and get data. So for example, Heidi asked, don't HIPAA rules prevent us from being given ER data on admissions and visits related to drug and alcohol use? How do we get to hospital ERs on our side? So if you want to quickly maybe give a couple of strategies to Heidi, and then your contact information where if she wants to be able to follow up with you.
Yeah, sure. And that's a really important question, I think, especially for medical stuff, right? Because there's a lot of rules and regulations around how that works. And I know that, there are strategies, but to a certain extent, right? Because you can get hospitals more involved in what you're doing, but that doesn't necessarily guarantee that they're going to be able to hand over the specific emergency room data. So I think the strategy is first figuring out what are the limitations and regulations that they feel comfortable with, right? Because we never want to ask a partner to do anything that falls outside their comfort zone. I think the next piece, and certainly as a former evaluator, the question I would ask is, what's the kind of consequence data that you're trying to get from the hospital, and if there are rules or regulations that prevent that, are there other ways that we could get that information, right? So maybe if those emergency room visits or a certain percentage of those emergency room visits involve some type of arrest, there might be something in either an incident report or an arrest report. And it may be easier to work it from that angle. So, I think it's showing folks that you have a common interest and then respecting their space and then thinking about, are there ways to gather that information around them if we can't get it from them. And again, my contact information is, the email is wgeary@cadca.org or 1-800-54-CADCA extension 280 is my extension. So I hope that helps.
Thank you so much, Bill. In the interest of time, we'll take one final question, and this question is for Shelley. So, Shelley, we did have someone ask about your healthcare provider training. I know you said that that's some next steps, but could you give us a little preview of what that might entail and the type of speakers or trainers that you would engage to be able to conduct that healthcare provider training?
Sure. We did one training, and what we did was we had two PharmDs to come in. We had a lady from the University of Louisville who works on addiction and geriatrics. And then we had a gentleman from the University of Tennessee to come in. And both of them talk about polypharmacy, pharmacology, and addiction. And so we had a healthcare professionals toolkit that we gave out to everyone too. And it went through like pain management contracts. We had information for them, resources, and things like that. And then we're trying to do another training this coming spring. So, and if I didn't answer any of the questions, I put it on the chat line that if they'll get a hold of me individually, either by phone or email, then I can get them whatever they need.
Thank you, Shelley. Would you be willing in the chat window to also tell anyone still on the line your email address so they can contact you? Are you open to that? Then go ahead and type that in the chat window. Everyone, Shelley's going to give you her email address. So if you're looking for, I saw lots of requests for the pain clinic ordinance, copy of that. So they were definitely pioneers in that area. I think, Shelley, also some people were interested in your school policy, which sounds very progressive and exciting. And then anything else, you're welcome to contact Shelley. Her email and phone number are right there in the chat window, folks. All right. So let's see. I think that's all that we got to most of the questions, Natalia. How wonderful is that?
Mm-hmm. Okay. Well, thank you so much, Shelley, Maureen, and Bill, for taking a few questions. Really appreciate that. That almost concludes the end of the webinar. On the screen now, you'll see just a few resources that you might find helpful in your efforts to address this issue in your community. So feel free to take a look. There's our prescription drug abuse toolkit that's online and free at preventartsabuse.org, as well as a number of other resources that we've listed there. And then finally, I did want to just give a quick reminder that our next webinar in the series is on January 20th at 3 p.m. And more information about it, we'll be sending out information about it through various ways. We'll have it on our website and through our weekly newsletter, Coalitions Online. So if you're not already subscribed to our newsletter, I encourage you to do so. And feel free to send me an email if you want to be subscribed. My email address is just nmartinez@cadca.org, and we'll type it in the chat window. But that's pretty much it. I really appreciate all of you joining us today, and I hope you'll join us for our next webinar on January 20th. And thank you so much to our presenters for sharing some great information today. Thanks, everyone.